Dr. Palafox, we are here because you're getting the inaugural Distinguished Alumni Award. And I want to talk about, how this school shaped you into the research physician you've become.
Thank you, Matt. That's first, hello to everybody, Yahweh and Aloha. But I think, Matt, that's a complex question. But if I were to break it down, I think the shaping how the medical school, how JABSOM affected and shaped me is a very kind of long and involved story. And I think I'd like to capture some of that. And so certainly when I thought about medicine, I wanted to be a good clinician, and at some level, and I wasn't sure how, I wanted to make sure that I helped those in greatest need using the clinician skills. And so the medical school, certainly as it frames what I've become, it certainly forms, helped me form and give me the fundamental clinical knowledge and the clinical skills. But in the process, the medical school is so much more than that. And it also does things like form my ability to use JABSOM's clinical networks and partnerships. It also helps me frame and act on the societal needs that JABSOM feels are important. And it also, the biggest part of it is JABSOM framed me by the people in it. And by people in it, I mean not only my mentors and professors and so forth, but the actual students that were around me. So to take a little bit more depth into this journey, if I were to start with, I began in the Imiholo program. And so I began and I thought that would be my way in. It would, and certainly the Imiholo program prepared me to have the rigor. And I was in the second Imiholo class ever. And it was structured in a way very different from now, where we started off with 21 students. At the semester, we had 11. And in my year, 4 of us got in. And why I mentioned that story is the Imiholo program was how JABSOM initially helped to shape me. Firstly, it was the students in it were were from the Pacific Islands. There were Samoans, Native Hawaiians, there were Vietnamese, there were Chukis, there were Marshallese, there were Yappies in the classroom. And where I'm going with this is only 4 of us made it in. None of them were from, Yap, Micronesia. Even the Chamorros who were in my class didn't get in. But all along the way, they shared with me what their stories were about. And so I knew nothing about the larger Pacific. I knew nothing about the plights and how bad their health systems were. So the first part of my JABSOM story is the Imiholo program, which took me into understanding how other people in the Pacific not only were treated, but what kind of health care they received. And so it provided a wider lens for me about health care, the needs, and certainly about Pacific peoples, a lot of the cultures I didn't know. And so when I was in JABSOM, I developed Imiholo, I developed many new friends. But then, stepping into the part about how JABSOM shapes you. So there was an Imiholo program. Then when I got into the, JABSOM itself, I had just these wonderful professors, and some have passed already, John Hardman, and, the dean at the time that also helped shape the Imiholo program is Dean Terrence Rogers. But it was one of these things where you really understand how the teachers around you help shape what you do. Dr. Ben Young was critical in not only the Imiholo program, but shaping how I think about the Pacific and what I do. But there's a lot more professors I can talk about.
Well, let me ask you this.
Yes.
During your time at Imiholo, being exposed and making friends with all of these different backgrounds, right?
Right.
Did that kind of spark your desire to do the work that you're doing now in the Pacific?
That's a very astute question, because in fact, it created my desire for learning more about the Pacific, because I really saw the have-nots, and I saw that many of them were extremely bright, and I mean extremely bright, but they just weren't prepared for the medical school curricula. But they were, you know, they could stand head to head with anybody. But when they told me their stories, Matt, I actually didn't believe them. They painted a story about their health systems that was so grave. It was, running out of medicines. They didn't have enough doctors. People would die without any care. They didn't have any antibiotics. They would run out of all these different things. And also, when they tried to come here to Hawaii, they wouldn't get the time of the day. So it was one of like, how can this be true? They're part of the U.S. At that time. They were territories. And how could the U.S. possibly... I knew the United States as, a very, a country that took care of their own, especially territories. But it was just such a story that I told myself during that time. After I finish, I'm going down there. I'm going to train up to go down there. I want to see for myself and just understand it a little bit better, because it was so... Is this even possible?
It was hard to believe.
It was hard to believe.
So what year was that when you went down there?
So I actually went down there after I finished medical school and residency. The first year I showed up down there was 1983.
Okay, 1983.
Right.
And was it as they painted? Was that picture the reality when you went down there in 83?
The picture was not only the reality, it was worse. It was, when I went down there, I ended up in the Marshall Islands. They actually flew me to many different sites to be there. And I was going to be there for 2 years. I trained up for this. And, when I was in the Marshalls, I could see 120 patients a day. Made no difference. The system couldn't take care of it. And oftentimes, there was no blood bank. It was a walking blood bank, meaning that if someone got into an injury or car accident or got bitten by sharks, which is real sometimes, is that you had to go on the radio and say, who has this blood type, and wait to see who shows up. And a lot of times they ran literally out of antibiotics. They ran out of, they had a hemodialysis unit that had to help close because they couldn't run it. People were suffocating because the unit couldn't run. They couldn't run the machines that they had, and on in the wards and so forth. And it was quite, and then even the mental health was such that they said, can you help us with the mental health department? I said, I'm not a trained psychiatrist, but I'll see what I can do. And I went, and where they took me? They took me to the jail. And there were these 3 gentlemen, mental health issues, that were in jail behind these rusty bars. And they were clearly psychotic. But it was that level of have not, and I was just kind of stunned, by that degree of,
And where were you in your medical career in 1983?
So in 1983, I had, so I started Imihola in 1975. I had finished medical school. I knew I would go back so I had finished my residency training at UCLA. And then I came back, and then I said, I'm going to the Pacific. Never was to these areas before, ever. And I went there, and this is what I saw, and this is what I experienced. And so from then on, I was going to stay 2 years. Matt, I stayed 10. I stayed 10 years there. And it was because I said, what can happen here? And so I got involved in many other different programs, including taking care of designing programs to take care of nuclear affected victims from the U.S. nuclear testing program there. A lot of radiation issues and displacement of people. Helped with many things. They had severe kwashiorkor and marasmus matrices, protein and calorie malnutrition. And so we had these protein and malnutrition pediatric wards, severe vitamin A deficiency with night blindness. And the odd part is these were areas where there was actually enough food to take care of that was vitamin A rich, that they could have given. These are islands, but it's the way that they had urbanized. It's the way that they had adopted Western ways of eating that totally drove the equation the other way. And so what we did was, how do you change that, the social structure? And anyway, so those are some of the things that I actually saw and felt. And then I saw the rampant, which is what I worked in now, cancer and NCDs that were just skyrocketing. Again, lifestyle. And from a culture that was really very healthy, like the Native Hawaiians a while ago, they had now adopted eating and lifestyles that were sending them into significant diabetes, cancers, and those types of illnesses.
And so I want to ask you this, kind of bringing it back to JABSOM, right?
Yes.
The seed was planted during Inihola. Oh, this is something that I want to explore more.
Right.
I want to investigate what it's like in the Pacific. During your time at the medical school, was that desire nurtured? Like, what did the school do to kind of keep that passion alive while you're training to be a physician?
So what it did was it really, the Inihola program let me see that, the medical school at the time wasn't very diverse, but they were striving to be diverse, and the Inihola program was there. So I said, okay. And the other thing it allowed me to do is, I was a little bit maybe a rogue, a little bit, So one of the things that allowed me to do is, there was another medical student and I, his name was Kevin Coons, and another woman named Ann Warren. And Kevin and I were sitting during a medical school event, and we just said, we want to have people know about the other cultures and appreciate. So he and I actually said, we're going to write a book in medical school, a handbook on cultural training and have languages of different programs. And so he and I begun this, and then we thought, and a lot of my classmates actually said, hey, Palafox, you'll never pull this off. But where I'm going with this, you know what happened? I talked to other medical students. Native Hawaiian community, they wrote the Native Hawaiian that were in the school. The Micronesians, they wrote it. The Filipinos, they wrote that chapter. The Samoans, one of my classmates, Louis Fiatoa, he helped write, and his wife helped write that chapters. We wrote a chapter on the Howleys, and we just created this wonderful book. And the dean at the time, Terrence Rogers, liked the project, so he said, you know what, this is something that we can get behind. And he provided an office at the Lusitana building, but he said, you need an office, there's an office, and I will provide $5,000 to help you get this published. And, so it kind of put me on the spot. Yeah, you got to do this now. But the students pull this off. Japanese Americans, Chinese Americans, Koreans, they each wrote the chapter from the medical school, medical students. And I just saw this heavy interest in people wanting to share who they were and their cultural nuances. And so we put that together, and not only did it become quite a hit, and not only for clinicians, but in nursing and so forth. And then the AOA students in 1987 published a second version of it. So, and this was way before the, wanting to know about all the cultural things. This was, the predecessor of, cultural humility and all these things. This was but it was just an interest. So that's how it helped.
So talk a little bit more about this handbook. What's the contents like? Like how different cultures approach medicine?
Yeah, no, it's more, in every culture, we ask the questions, can you provide, so in the cultures, the Micronesian cultures, for instance, we had the Micronesian students, and some of them were fellow EMI students. Some of them weren't in med school, but folks I knew, but some were in medical school at the time. And they provided translations, simple translations of what is pain. Some of the things about how you say Where does it hurt? What's bothering you today? The hello, the goodbye, the greetings, the kind of key words that help someone establish that level of compassion and contact, and have actually a basic way to get into there was some questions about, menstrual cycles and, do you have your period yet? Those kinds of things. And then the other part was really about what are some special things, traditional things that people have to know about your cultural practices in medical care that the medical community needs to know so they don't interfere with your first level of medical care, which is usually the cultural practices. So it laid a lot of that out. So it was the language pieces, so that the community, and then it was, what are your cultural practices like? And this is what the students put together. And they wrote it up, and they did it with great poise. And sometimes I was waiting for them. So I kind of was trying to put things together, and they said, here we are, and we want to do this. And they did it. And that's, to me, what told me there was that. Then, the next thing that helped me shape, which was not the formal medical training, because that was great, is that I became part of AMSA, which is the American Medical Student Association. But AMSA was about health policy. And so they had me go to these conferences nationally about all these health policy issues about healthcare and diversity in healthcare and populations without, but I really realized it was nationwide. Not only was it in the Pacific. And so it helped me take on a lens of health policy and how that shapes healthcare. But this is coming out of the medical school. So it was these kinds of experiences and then the other thing that I got to do, and they let me do it, meaning that sometimes I would have a test and I talk to Dr. Hartman, and I say, I was in this really good outrigger paddling team, and there's medical school you have to go to, right? But we had a really strong team, and there was distance racing. So when we had the races, I would have to talk to the teacher and say, can I go to these outer island races, sometimes on Kauai, wherever? We talk and say, you got to make it up in this. But the point is, they helped accommodate, me being the steersman for the team. That was really good, and I enjoyed. But it helped me to do these things and to keep contact with this, and then formulate how to take what I learned in Imiola and then the clinical skills and transform that into the next stage of doing what I do.
So, talking about the policy that you're involved in, and you are now heavily involved in policy in the Pacific, you didn't think that this is what you were going to do when you came into medical school. You were thinking, hey, I'm just going to be a straight-up doctor, which you are. But now you're really an advocate as well for the Pacific.
That's that is very, very true. And certainly, as you mentioned, the first taste and its importance became clear while I was doing the American Medical Student Association things and looking at it in context of what's happening in the Pacific. And then what transpired and kind of moving forward a little bit is the next role that I was asked to do was in shaping how to address much of the vitamin A deficiency, the non-communicable disease issues in just the Marshall Islands, but in some of the other Pacific. I was asked, well, can you help with this? And I knew that being a clinician, it's not one guy, even if I was doing perfect clinical medicine, you couldn't do that. So it's changing the policy. So I had to work with the president of the nation, with the senators and so forth, and with the health system there to change how the health policy and culture worked on these things. So you're exactly right. It's thinking out differently of how do you work with the systems that way. And then it also plays out, Matt, when I was asked, after I finished 10 years in the Marshall Islands, I was asked to help set up the department here, right? And so I was, a chair for, 13 years. But in that time, part of the policy issues were how do you get primary care, which was not an emphasis. I'll tell you, when I first went to medical school, very few people entered into primary care. I think I was one of two family physicians that went in to primary. Many folks went into specialties and subspecialties because it wasn't the emphasis. But when we started the department, I think there was a shift.
You're talking about Department of Family Medicine.
Family medicine and community health. And then so at the time, it was then, we wanted to expand it. And so a lot of the policy issues were, we went to expand it into Kauai and into the Big Island actually at the time. This was in 2005, 2007 with Chip Hixon. And we had to interface with the legislature to get money to do it. And when you start interfacing with other islands, you just don't walk in and say, hey, we're going to start. You interface with the policy folks there, the Department of Health folks, the hospital folks, and the different folks in the health systems that work with it. It is about policy and who controls that policy and get everybody to work together. So the policy issues were huge. And then just as I can mention others, but even the nuclear issues, I had to do testimony to the U.S. Senate about the damages that were done in the Marshall Islands. I testified at their request to them, to the Department of Energy, to, several times. I helped the Marshall Islands do what's called their change circumstance document. They actually invited me to talk in Tonga to the executive leaders about nuclear policy in the Pacific. But so you're right, it's that policy lens that helps drive this. And so it became one of having to be comfortable. And I've had to talk with some of our legislators who are medical school friendly and cancer care friendly, and some who are not. You know what? And you have to be able to present your view and talk and share why this is important. And in the end, it's not solving it, but certainly get someone to understand that there is another view and you understand their view. But anyway, policy, huge. And yes, the medical school, Imihola, helped shape, and I can tell you some folks who kind of beat me on the head with this that are key in what I've done is Nalina Andrade. She was someone in the psychiatry. She was actually 1 year behind me in medical school, I believe. But she was also part of the EMULA program. But then I went to the Pacific. But she was chair of psychiatry. But she was someone who actually taught me and helped me understand the nature of health policy in Hawaii. And if you're going to do things around, primary care, you just don't walk in and say you're going to build a department. This is a larger conversation, and you just conversate with hospitals, other specialties, because other specialties, a lot of centers and the health systems in general, don't feel they don't believe in the same thing you do. Anyway, so that.
I want to talk about, your work currently now with the Pacific. We just came from a meeting with you and the group, the Pacific Cancer Team. Yeah?
Right.
What is it that you're doing now with them?
Yeah. So in the same matrix, you find out that as you know, JABSOM brought me into being a good clinician, having good fundamental skills of besides the knowledge, and then brought me into the policy realm and about the different ways to configure things and divide as chair. But the next step, which I found out, and again, I would have never known about this if I wasn't in Imihola and in the Marshall Islands, is really learning about population health. And that's the lens of medicine of how do you not only deliver individual care in high quality, but how do you affect the health of an entire population, in this case, the Pacific. And so in doing that, it was really talking to folks and saying, well, how do you do that? Do you just see as many patients as you can? No, you have to change the system. You have to do the research to see how to change the system. You have to get the grants that allow you to do the large programs for non-communicable disease control. tobacco control, reorganizing how the health system does things, like forming what we have now, the Cancer Council of the Pacific Islands, putting in a cancer registry. All of those are foundational elements of research, but it's the way of thinking of, in order to affect population health, taking the knowledge that Imihola and the medical school has helped me with in the policy. How do you do that? You have to get grants. You have to have an organization behind you. You have to be able to do research. And you have to be able to write for the grants and get the grants. And so in that matrix, incrementally, had to learn how to do those things, get partners behind it, and get all the folks you see to help you do that, and the other departments and the folks who do that well. And so that's why part of it is I work with the Cancer Center. I worked with the groups in Hawaii like Papaolakahi. I work with Department of Native Hawaiian Health. But it's all the different groups. I work with the different PIHOA, which is ministers and secretaries of health throughout the U.S. affiliated Pacific, because they help get that money to drive the research, drive the knowledge, because it's through the research and creating these bodies that you actually create new paradigms to do things. You explore new ways to do things in a better way. You explore ways how to reorganize systems. And importantly, you find out how to disseminate that so that the doctors and clinicians in Hawaii and the nations understand that they have to understand this. It's not only reorganizing that, it's reorganizing the thinking in Hawaiians. Even, during COVID, the reason that the Pacific Islanders didn't have, they had the highest rates of COVID and the highest death rates, and this is besides the Native Hawaiians. The Native Hawaiians did relatively well in proportion to their proportion of the population, but the Micronesians and other were getting hammered. They have 4% of the population, they had 29% of the infections, and twice to 3 times the death rate of anybody. But it wasn't until they were allowed to then develop their own community health networks and community health folks to then intervene. And you know who was at the helm? Like Rick Custodio. He was JABSOM graduate and helped train some of these folks. We had entire interventions where it was based on using their community wisdom, because the community wisdom that was in Hawaii, they didn't know how to do that, but they thought they could do it, and it drove the problem deeper. And so finally, when it happened, at the end of the day, they had less than 3% of the infections, and they were able to deal with a lot of their, because they had the appropriate interventions with their own people.
And it kind of goes back to the handbook that you wrote so many decades ago.
Right, but but that's the research component. So all three, the policy part, but it starts off with the JABSOM thinking, and then the different mentors that I've had, and seeing what other people can do and would do, and see that all these folks who just keep standing up and get busted up and just keep going, and they just I'm talking about some of the real tremendous programs, Jill Mori's and the homeless, and Craig Nakatsuka and the Seafarers program, and the docs helping the folks who can't even step into the soil because they don't have the visas, but they need the medical attention. Every Saturday, he's there taking care of them, silent, effective. There's tons of programs like that, but anyway, so I'm derailed here, so help me get back on track.
I'm kind of wrapping up this part of your work in the Pacific. Compared to what it was like when you first saw it for yourself in 1983, more than 40 years later now, what strides have been made?
So thank you for that question, because that's what matters, is what has the progress been? Sometimes we can just spin our wheels without knowing what to effect. But the strides I've seen is that throughout the Pacific, and JABSOM's been a very strong part of this, is there's now clinicians who are blood that are part of the system and can affect the system. I'm talking about, Stevenson Corti and Dr. Yano and Palau, and there's two Marshallese doctors, Dr. Ricklin and Dr. Alec, who are Marshallese, the only two Marshallese MDs. And the third one, by the way, is Dr. Alec's son, who's in the internal medicine residency in Kaiser right now. But anyway, it's, there's Pompeians, there's Yapese physicians, so it's the clinicians, it's developing that capacity. Further, there's other people in leadership positions in health and in policy. Some of them, actually, the policy folks in many parts of the Pacific came through the EMEO program, and they didn't finish to be clinicians, but some of them I know have been senators, secretaries of health, in the Federal States of Micronesia, and there's a director of health in Yap. There's Miguel Demapon, who became a chief justice. But the influence has not only been, but it's things that definitely touch health and the well-being of people. And so, and then there's, I think, a stronger sense of the folks there wanting to take the knowledge and reshape it themselves. It's like, no, you stay out of my face. Kind of, when we invite you, yes, come and help, but don't just come in and do research and talk. And we want to make sure that we have a trusting relationship with you. So the first thing we want to see is that the trust. But where I'm going with this is, I think because of the many students, residencies now who have joined and worked down in the Pacific, starting with some of this work that we talked about, then the Pacific can see there is a partnership and a relationship and more of a trust. There has been some that have not worked out real well. But I would say overall, even now with the MD5 unit, I can see with them rotating down there, I see the spark in the eyes of some of the students that I just went down there, that I look at them and they go, wow, and what else can we do? But so I think from the standpoint of what's transformed, the school has transformed, the students have transformed, the residency, and the country certainly have a greater ownership because they see that it doesn't matter what someone else from the outside does. If they don't own it and taste it and do it, it won't be sustainable. And they realize it's a capacity issue. It's not just the technology. In fact, the technology has sometimes sent them down the wrong path. And so I think, and there's many stories I could talk about that.
So I want to talk about the other aspect of your career, and that's being a family medicine physician. What made you want to go into that specialty?
So I think one of the things about family medicine is it's really about all stages of life. And it's really about taking care of, being able to take care of a wide variety of issues that come up frequently. So you have a wider breadth, and you can call on the folks who have the depth. So you can call on the pediatrician, you can call on the endocrinologist, and what it does is, and I think I mentioned to you, Matt, I always wanted to see how it could affect people with the most need. And so that would mean I'd have to go into areas where there's not going to be a lot of, different specialties. And I'd actually have to do the best I can. So that's why family medicine appealed to me, because I'd be able to do that in rural settings, in mission settings. And so I wouldn't be able to do that if, let's say, I stayed at UCLA Hospital and Clinics. And I went to UCLA Hospital and Clinics for a very specific reason, but it's not, So, but anyway, that's why family medicine appealed to me. It's, you can go rural, you can go do missions, you can go, and talk widely.
And I want to talk about, how you've used that so well, because you brought it with you to the Pacific, right? And then you're also still doing it right here at home.
Right. So, I think to me it's partly, I think medical schools and the culture of medicine shifts to meet societal needs. And so I've been lucky on the cusp of coming from where family medicine and primary care were not in favor. In fact, several people tried to talk me out of it. They said, one, you're not going to make money. And two, what are you doing? You can use your talent in a better way. But I had my own thinking about that. So what I'm thinking about in the transition, it turns out, as we spoke, that in the Marshalls, that's exactly what they needed in those countries. They needed someone who could deliver babies, who could look in an eye and take care of basic eye care. I actually set really complicated fractures by reading about them. I was able to do basic mental health, their psychiatry. They actually helped me. Their hemodialysis unit was collapsing because they didn't have the supplies and so forth. So I had to run it for a while. Family physician, what do I know? But I was able to because I knew enough to then train myself up to do that. And I wasn't afraid to, I delivered outer islands. Outer islands in the Marshall Islands means no running water, no electricity. And we're talking in a hut. You do deliveries. And, just a side comment about primary care, I learned more about some methods of delivery from traditional birth attendants in the Marshall Islands who couldn't speak English, who didn't have any kind of high school education at all, but could deliver twins and mobilize the baby to be in a vertex position like magic, and deliver things I didn't think on an outer island. But anyway, my point is primary care allowed me not only to do lots of these things and become effective doing that, the inpatient, outpatient, and then they asked me, could you help develop a program taking care of nuclear affected people? And I said, I don't know anything about that. But having a primary care background helped me kind of break that down a little bit. And truth be told, if I didn't do it, and this other guy who was there, actually a Canadian physician who, was a primary care doc, it wouldn't have gotten done. So we built this program. So and then moving forward, it was clear that, coming back to Hawaii, and this is going to be after I finished my MPH at Hopkins and some research stuff, is this was 90, and they were just starting the family medicine department, but the needs had changed of Hawaii. They realized we need more primary care docs. There weren't any. There was no family medicine department. So they asked me, could you help start it? So two people helped start it. We're both JABSOM graduates, Dr. Curtis Takimoto Gentili and myself. The two others were actually mainland born, and they were here. They were great. They actually very powerful and with their knowledge pieces of doing it. But then we continued it from within, and so so we developed it, and it was such a great need, and it was a hit. So initially, we wanted to develop it so that it would serve the rural needs. So that's why we initially developed it at Wahiawa General Hospital, rural community hospital. Didn't have all the bells and whistles. In those days, they did deliveries. They had a small pediatric neonatal unit. They did surgeries. They did everything there when we started it. And that was ideal for how we wanted to train the residents, because we still could call the folks in town, hey, Dr. Kosasa, we got this problem with this delivery. And what do you need? That kind of thing. Dr. Haruno, ICU, what do you need? But anyway, so it was developing there because that was a need. And then, of course, that hospital couldn't sustain it after a while. Just they were too small. So then and before we started it there, what few people know is a lot of folks wanted the residency. Some big hospital systems wanted the residency. I won't name the other really big hospitals, but they all wanted it. But we said, no, we want to set up there for the reasons I mentioned. But everybody started to realize we need primary care docs. We need family physicians. So again, that being on the right time in the curve of what's needed. Then HPH picked us up, and now we are at HPH, and a lot of conversation, and other hospital systems all started looking of how to develop it, and moving it to the outer islands, because primary care in the outer islands is probably the first residency that can go out into the outer islands family medicine, because it reaches that rural population, it develops that network, and that's what they need initially. Do you need specialties? Definitely. But that is the base. And I think, so that's why. And then I still precept, and I did, inpatient with the team until 2022, until there were younger guys who could do it faster and better than I could. But then I still do the care and work with them all the time.
And you still see patients?
Still see patients.
Why is that important to you?
Yeah, so I think kind of, as we had mentioned in the medical, being at JABSOM, what helped me understand all the systems we talked about is becoming a good clinician first, and understanding how the body works and so forth, then putting all these other systems on top of that. And so what keeps me abreast and in all the work, even the research I do, is I need to keep abreast of medical care. It is changing so rapidly. The amount of antibiotics now, the amount of biologics, the amount of immunosuppressants, the cancer drugs, the imaging is all changing. But you have to be able to fit all of that changing paradigm into the new systems, because you want the Pacific, for instance. If you're going to talk to them about the changing paradigms, they're going to want to know, well, how can the new technology help us or not? And so you have to know about these things, and you have to know what may be good, what might be too expensive, what is really part of population health versus individual health. But it keeps me abreast, and also the thing that keeps me going mostly is talking to patients, and that one-on-one. And so sometimes when I can, I work with the home clinic, and I wish I could do it more, but I do it when I can. And then so it takes me there, it takes me to the clinic. A lot of times when I go into the marshals, they ask me, can you help see these patients? I get calls all the time from people in the Pacific. We want to refer a patient here, and I need to be able to talk the language of this medical system and that medical system to see what's appropriate. So all of that, I have to have that knowledge. But I think the magic to me is still seeing the patient, seeing the mothers. I work in the clinic and our clinic sees some very complex patients from difficult to reach demographics. And that you can see, and it helps reinforce why you work with policy, why you have to do the research, why you have to fold into getting multiple partners, the social workers, the whole team on your side. This is not a physician thing, it is all of it. And until you get that going, it's kind of spinning your wheels a little bit. So I don't know if I answered your question.
No, you did. You did. You talked about, the importance of family medicine, and really how that was the specialty that allowed you to do what you're doing today and throughout the course of your career.
Yeah.
And I think that's very important. Do you want to share a little bit about how, and you did touch on this, about how much the department has grown over the last 30 years? Because we are now out on Kauai, we're out on the Big Island with different residency programs of their own.
Right. So I think, and I truly want to celebrate this. I think, again, fortuitous or however you shape it. I think the department had, like you said, grown immensely. We've graduated 155 residents so far, and since 1993. But within that matrix, there's been some very key folks who have come from the residency. So Dr. Lee Bun Conseil Lam. So not only was she key in helping form the residency and the Pacific programs, but she now is a major force here at the Medical School as Associate Dean. Jill Omori was our graduate. We have several who have, Dr. Christina Lee, who was at Kealoha at the time, is a director of a Waimanalo Community Health Center. But we have folks in every part of Native Hawaiian health systems. We have folks who have graduated into the community health centers, and actually our heads are very key in Waianae and all different places. But why I mention that is because the growth was dependent not only on the leaders, but the product. And the product actually formulated, family physicians. Dr. Sheldon Ricklin is a family physician. Dr. Wilford Alec is a family physician. The Marshallese. Stevenson Corte, Palawan, family physician. Thane Hancock was did a lot of work as a family physician. But my point is a lot of the leaders then took it and moved it. And so besides it growing in and of itself, and there was a societal need, and then there was a vision that how do you then expand it quicker? And I want to really say that Dr. Chip Hickson, I was chair at the time, and he said, this is important, and several folks from within, said this is important, and so how do you grow it? And so we went to the Big Island, and actually the foundations of the Hilo Family Medicine Residency, through policy and other things, we actually helped formulate the basis for it and the foundation for it, and that gave it its foundation. At the time, for many reasons, the medical school didn't want to take it on in HRP because they thought they didn't want to get caught in the financial part of it. But that now is promoting family medicine. Then in Kauai at the time, we also started there at Wilcox. And this was 2007, 2008. We went to the legislature, policy stuff, got lots of money to do it, $1 million to do it. It didn't work out at the time because the policy and system wasn't ready, but now, fast forward, 2024, 25, it is there. But so everything is a progression, and it's as well, but it's a credit to multiple layers of people. So it's not just the department, it's the energy. It's one of the folks that I want to, shout out also JABSOM, Dr. Randall Suzuka, rural medicine, family medicine. He kind of is one of the guys that's behind this energy and help, figure out how to move this forward. And so it's all of those things that made it so, and it's continuing to grow. And there was even a time, and I can just share this, we were talking to Kaiser about putting in a family medicine residency. This was 2007, 8. And long story, but it didn't work out, but then they made an internal medicine residency, but it's a primary care internal medicine residency, which is run now. But the point is, it's taking the hits, and a lot of folks said, you're not going to be able to expand the residency. You're not going to, and then we were on the heels of, there was a family medicine residency that was part of the Kaiser system, and from between 1997 to like 1980, something like that. But it only lasted 3 years because there wasn't the energy behind it. There wasn't the force behind it. So after 3 years, it ended. And then there was a gap until the next one started in 1993, which was this department. But you can see it just was the right time, and some of the forces that were at that time helped to move it along. Dr. Nathan Wong, for instance, Lily Ning, very powerful primary care. So again, it's a credit to multiple forces, and then the deans at that time. So again, when I became chair, well, when the department started, it was actually Dr. Gil Branson, but he was hematologist, oncologist. But he said, no, this is important, it has to start. And he was the one that said, can you help start it with, and then along the way, when I became chair, JABSOM grad, you know who was at the helm? It was Dr. Cadman, and then Dr. Shoemaker. So me becoming chair, which then I had 13 years of it, Cadman, Shoemaker, who's a dean now. So it's one of these things where you don't necessarily know what's going to happen, who's what. These are all JABSOM guys, JABSOM graduates. And so it's one of energy behind it at multiple levels, and looking at it through that lens, and it gets pushed along by the different deans and so forth who believe in it. Dr. Hedges, and certainly current dean, and you have the push from inside. So it's one of going, and I do think it is critical, family medicine, because it's foundational in all life things. And I wouldn't be able to do the breadth of research I do, cancer systems, I work with pediatrics, I work with vitamin A deficiency, basic things. And actually, and in fact, other departments actually asked me to give talks. Like I've been asked to talk, Dr. Ken Nakamura, who's a heavy hitter, JABSOM grad, chair of pediatrics. But he invited me to give a talk to the pediatrics researchers. I'm giving a talk to the OBGYN researchers, but it's because there's parts I can do. I'm not an OBGYN, and I definitely don't know their realm as they know it, but I do know some of the things that they're interested in, and how do you partner that way? So family medicine,
I'm going to have you go back really briefly, because
yes.
you're starting on a thought where
Yeah.
if it wasn't for family medicine, the breadth of work that you do wouldn't be possible. Is that kind of the road that you're going down?
Yes.
Share a little bit more about that, please.
So, so the breadth of family medicine. So when you are in medical school, you get the fundamentals, the basic physiology, the chemistry, the pharmacology. And then when you go into a specialty, it teaches you about how far to go in depth about certain parts of the life cycle. So if you're a pediatrician, you go certain age group. If you're an OBGYN, maternal child health, right? If you're an internist, you do that, but if you become an endocrinologist, it's a very specific system. Infectious disease, a very specific role. But in family medicine, you have to know a little bit about all of that to be effective. Obviously, and I just want to emphasize this, you don't know the depth these guys, and you never will know that. But you have that resource because they are there. That's why I can call these folks who are my friends, JABSOM grads who are there, and they say, you need assistance, give us a call. Clayton Chong, oncology, Paul Palalai, other oncologists. Anytime you want to just pick up the phone, and you know what? It's happened. But anyway, so when you know the breadth, you feel comfortable working in doing multiple things. And I remember a story. There was a visiting, and this might help. There was a visiting ophthalmologist from, actually he was from Harvard, and because we were doing a particular project, and he was visiting the Marshall Islands, right? And he was wandering around the hospital, and he was an emergency obstetrics case rolled in. And they said, you're a physician, can you help deliver this? And he was beside himself. He didn't know what to do. He didn't know where to start. He just kind of froze, and then I just happened to be there. Then they, came in, and then it was a, delivery, and a little bit complicated, but it came out all right. But the talk in the back was, how can a physician trained in the U.S., he doesn't know anything. Obviously, he's a Harvard ophthalmologist. He knows a lot, but he didn't know about that piece that goes across common things happen commonly: birth, death, diabetes. And so you have to know how to take that apart. And so that's why, as mentioned, being a family physician, so it made me look good. The nursing that I helped with made him look bad. But it's only because of the situation, right? But that's why family medicine. And then taking that, when I apply for a grant, if it's a grant, for instance, in, which we do, cervical cancer, screening and development, I'm not an OBGYN, but do I know about women's health and cervical cancer screening or cancer screening? Oh yeah, that's what we do. So I can write the grant. I know the science, I know the strategies, I know how the systems develop, so I can write it. But if I was, let's say, an internist who didn't deal with that, cervical cancer screening, that's a pretty narrow thing. But it turns out that's an important thing in the Pacific. If they wanted to learn about cancer registries, I knew that we saw all the factors, the risk factors that cause cancer, tobacco, in the case of martial arts, a little bit of radiation, it's processed foods and so forth. So all those kinds of things you learn about and have to deal with as population health as a family physician. So when you have a grant that says, how do you prevent cancer in these systems? You say, well, I got to put in a registry, I got to do all these things. And you're able to do it because you have knowledge about these things and you can apply it. And you see the application as relevant. And you can explain it to other people in the system.
Over the last hour that I spent with you, I already know how I'm going to frame this video. It is going to be Dr. Neal Palafox meeting the needs of Hawaii and the Pacific. Back in the 80s, you went out to the Pacific Islands and saw the need there and helped. Here in Hawaii, there was a need for family medicine physicians. You saw that. The Department of Family Medicine was created. So throughout the course of your career, you have just been meeting the needs in the Pacific region and here at home. And I think that those who nominated you, who've actually been with you, alongside you, through the decades, realize that, and that's why they've bestowed this Distinguished Alumni Award on you. What are your thoughts about that? How do you feel knowing that this recognition is for you?
Wow, thank you. That's a difficult question, but I've been actually reflecting on that quite a while, Matt. And the being bestowed this award it really makes me feel very humble and brings me great sense of humility. And it's because the work that I do is not my own. It's really a reflection of multiple people, partners, JABSOM as an institution, but also multiple people who are heavy hitters that have come through JABSOM that are friends and colleagues. And I've learned just a little bit ago that there's 3,171 graduates from JABSOM Medical School since its onset, and half of those would have finished by 1999. So of those, I can tell you that I look at my colleagues and folks who I've graduated with, and many of them have done, to me, much greater work than I have, but also have provided because of what I learned from them, their work ethic, their energy, their refusal to stop working, and the different things that they've said that this is important. So for instance, in my Louis Fiator working with the Samoan community, Dr. Elliot Kala'awa working with the Community Health Center in Waikiki, Dr. Sherry Tifi now working with the folks in Africa. You have Libo and Conseil Lam who did so much for the department and with bringing the medical school towards at now the Jill Mori's, Craig Nakatsuka's, all these different people that Nalin Andrade's, Clayton Chong's. I can't even possibly list all these different folks that have contributed, I've learned from, and are part of this work. So to me, the celebration, and then there's my instructors and the deans and Ben Young, and that allowed me to come into the Imiola program and be what I've come. So what you're seeing, and if it is a light or this work, it's a product of many people. And so that's what it means to me, means that whatever they helped me with and pushed me along and said, you're part of us, and go Neal, go, or stop Neal, stop, that's the gang, that's the partners in the community and so forth. And it's the legislators and on and on. And then the other thing that I would mention about the HEA award is I actually looked it up and I said, what does this mean? It means to, embellish something or make something look good or so forth. But the deeper cultural meaning, from what I understand, it means is when you embellish something and make it look shiny and charming, whatever it is, what you are actually doing is integrating and celebrating it from the foundation from which it came. And so if that's what the award is, and taking that, and I can celebrate all these colleagues, and some who have passed, Emeraluli, very good friend, and, worked with them, and, very much Kikuni Blaisdell, and as teachers, and Dr. Irv Schatz. It's one of these things where they've been part of me, their story's been part of me. And then if that's what the HEA Award is, you know what, for them, it's a goal.
Perfect. Anything else that you wanted to add?
The one other thing that I do want to add, and I didn't know how to thread it in, but one of the graduates that's been so close to me and helped me finish, and a physician as well, as my wife, Dr. Momoi Kanoi. She is a family physician and a graduate from Imihola and the John Burns School of Medicine. So talk about providing energy and support for this HEA award. Thank you.